Cardiovascular system inspection. Technique. The evaluation of the cardiovascular system includes a thorough medical history, a detailed examination of the heart and the peripheral, arterial and venous circulation, and appropriate laboratory studies. A careful assessment will enable the examiner to identify the etiologic, anatomic, and physiologic components of a specific cardiovascular disorder as well as to determine overall cardiac function. The examination involves inspection, palpation, and auscultation of the heart and vessels. What to observe during inspection? Skin, precordial bulging and chest deformity, apex beat, any other pulsations in the major precordial areas. Procedure. Introduce yourself and confirm the patient's identity. Ask for the patient's consent before beginning. Observe the patient as he or she first enters the room. Is there any breathlessness at rest or while walking? Begin inspecting the patient in a seated position, unsupported if possible, and undressed to the waist. If the patient is too ill to sit upright, support assistance may be necessary. Inspect the skin of the chest wall. Check for cyanosis, pallor, scars, wounds, bruises, lesions, nodules, superficial venous patterns or dilated veins. Observe the precordium and chest wall for any bulging or deformities such as scoliosis, kyphosis or sternal depression. Identify if the apex beat is visible in the fifth intercostal space 1 cm internal to the mid-clavicular line. Next, look for visible left parasternal pulsation on the left lower half of the sternum. Look for visible pulsation on the second left pulmonary and second left aortic intercostal space. Look for suprasternal, root of the neck, and epigastric just below the xiphisternum pulsations also. Check for other pulsations over the chest wall. Finally, check for any abnormalities on the back such as spinal deformity. Cardiovascular system palpation. Technique. What to observe while palpating? Apex beat, parasternal heave, thrills, any palpable sounds, any other pulsations. Procedure. Ask the patient to remain in sitting position. If unable to do so, examine the patient lying quite straight. Make sure your palm is warm before palpating any patient. Place the palm of the right hand over the patient's left chest such that the palm covers the area over the heart. The heel rests along the sternum border with the extended fingers lying below the left nipple. Feel for the apex beat in the fifth intercostal space 1 cm internal to the mid-clavicular line. Note the position, area, amplitude and character of the apex beat. Next, feel for parasternal heave by placing the hand parallel to the sternum at third and fourth intercostal space on the immediate left of the sternum. Next, feel for thrills at the apex, second intercostal space right to the sternum, second intercostal space left to the sternum, and fourth intercostal space left to the sternum. Next, feel for any other pulsations at the root of the neck, at the front of the chest and in the epigastrium just below the xiphisternum. A pulsation in the suprasternal notch indicates aneurysm of the arch of aorta. Visible carotid pulsations may be observed in thyrotoxicosis, hypertension, aortic regurgitation, aneurysm of aorta, or in anxious patients. A pulsation on the right of the sternum may be observed in aneurysm of aorta if the ascending aorta is affected, under the manubrium sterni if the aortic arch is affected, and on the left of the sternum if the descending aorta is affected. Pulsation in the epigastric region is observed in thin patients who are nervous or excited, or in tricuspid regurgitation. Cardiovascular system, percussion. Procedure. Make sure your palm is warm before percussing any patient. Place the left middle finger, pleximeter finger, on the area to be percussed. The back of its middle flanks is then struck with the tip of the right middle finger, that is the percussing finger. Make sure that the percussing movement originates at the wrist and not the elbow. The percussing finger should be bent so that when the blow is delivered, its terminal flanks is at right angles to the metacarpal bone and it strikes the pleximeter finger perpendicularly. As soon as the blow is delivered, the percussing finger should be raised. Ensure that the delivered blow is no heavier than necessary to elicit the resonance of the area being examined, and the wrist joint must move freely. Exercise caution while percussing, as repeated blows can cause discomfort to your patient and even cause rib fracture. To identify for the left border of the heart, begin percussing the fifth intercostal space from the mid-axillary line and move medially towards the sternum till the note changes from resonant to dull. The left border should normally be at or medial to the mid-clavicular line. Since the sternum hides the right cardiac border, it cannot be percussed in most cases. Cardiovascular system, auscultation. Technique. The evaluation of the cardiovascular system includes a thorough medical history, a detailed examination of the heart and the peripheral, arterial and venous circulations, and appropriate laboratory studies. A careful assessment will enable the examiner to identify the etiologic, anatomic, and physiologic components of a specific cardiovascular disorder, as well as to determine overall cardiac function. The examination involves inspection, palpation, and auscultation of the heart and vessels. Proper use of a quality stethoscope is essential during auscultation. A diaphragm pressed firmly on the chest filters out low-frequency vibrations and amplifies high-frequency vibrations. It is routinely used to hear the first and second heart sounds, systolic murmurs, and the diastolic murmur of aortic regurgitation. The belt should be applied to the chest with very light pressure, barely creating an air seal, so low-frequency sounds and murmurs are appreciated. It is used to hear the third and fourth heart sounds and the diastolic murmur of mitral stenosis. Procedure. Introduce yourself and confirm the patient's identity. Ask for the patient's consent before beginning. Ask the patient to remain in lie supine. Raise the head of the bed 30 to 45 degrees. Expose the chest before starting. The normal first heart sound S1 is audible in each of the 4 classic listening areas, though its intensity and quality will usually differ in each of the 4 main auscultatory areas. Start with the aortic area at the right second intercostal space. Listen for normal heart sounds, other sounds and murmurs such as the aortic ejection sound and the murmurs of aortic stenosis and aortic regurgitation with the stethoscope diaphragm. Second heart sound S2 is best heard in this area than S1. Move the diaphragm to the left second and third intercostal space to listen to the aortic and pulmonary components of S2, the pulmonary ejection sound, and the murmurs of pulmonary and aortic regurgitation. Move down to the tricuspid area along the left sternal border at the left fourth and fifth intercostal space. Listen for the murmurs of tricuspid regurgitation and tricuspid stenosis and the murmur produced by ventricular septal defect. Right ventriculars S3 and S4 sounds, gallops, can be best heard in this area with the bell. Here the splitting of the first heart sound is best evaluated. Then move towards mitral area at 5th intercostal space at the mid-clavicular line, an aortic ejection sound, a mid to late systolic click, the opening snap of mitral stenosis, the systolic murmur of mitral regurgitation, and occasionally the high-pitched murmur of aortic regurgitation are also heard in this area with the diaphragm. The heart sounds are usually loud at the apex because the heart is in direct contact with the anterior wall of the thorax. S1 has a booming quality and is lower pitched, duller, and longer than S2 heart sound. S1 is usually louder at the apex than S2. A loud S1 is a classical finding of mitral stenosis. To listen for the third heart sound, turn the supine patient to a 30-degree left lateral position with the left arm extended upward away from the chest and the weight comfortably supported by the left hip, lateral chest and left arm. Palpate for the apex beat while listening with the bell of the stethoscope applied near the apex. Children, young adults and pregnant women may have a normal third heart sound. Listen for the fourth S4 heart sound. S4 is best heard with the bell of the stethoscope placed lightly over the apex, barely making an air seal, and is attenuated with increased pressure on the bell, that is, creation of a diaphragm. S4 is normally not heard in healthy individuals. It is important to auscultate all these areas with the bell of the stethoscope. Auscultation should also be performed in the sitting position since the heart sounds may be distant or even absent in the supine position. To listen for venous hums, move the bell of the stethoscope to the medial end of the clavicle and the anterior border of the sternocleidomastoid muscle. Turn the patient's head away from the area of auscultation and press firmly to listen for a continuous low-pitched sound during ventricular diastole. Physical findings must be interpreted in light of all previously collected data. The general scheme is to develop a postulate and test it with further history, additional observations or maneuvers on physical examinations, and laboratory tests.